Hello, welcome to today's Insta Live, and today it's a very special day because March is Endometriosis Awareness Month. So we want to talk about how can women with endometriosis get pregnant. So I'm going to invite Dr. Natalia from Vida Fertility, and I'm going to ask all questions we need about getting pregnant with endometriosis. And it's such a common problem that so many women have. So we want to ask all questions. How can we know if we have endometriosis, and how does it really affect our fertility? And how can we treat it? How can we improve our chances of getting pregnant if we have endometriosis? Let me see if I can invite Vida Fertility to join us. Or Dr. Natalia. Let's see which account is coming through. And for those of you who don't know me, my name is Andrea, and I am a fertility nurse consultant. Hi, Dr. Natalia.
Hi, good. How are you, Andrea?
Okay, I wasn't sure if you're
Good
joining from Vida Fertility or from your account. But anyway, we're here.
No, it automatically like switched into my account on my iPhone, and then that's why I was like answering you on this. But we do it for Vida Fertility today.
Amazing, amazing. And we want to talk about endometriosis.
I'm not sure if we have a good connection, Andrea.
Okay, can you hear me well? Can you hear me?
I can hear you well, but sometimes your voice is not. I can hear you. Can you hear me?
Yes. I can, yes. I was saying that we are talking about...
let's go for it. Let's try to do it.
We're talking about endometriosis because it is Endometriosis Awareness Month. And endometriosis affects a lot of women. And maybe we can start by talking a bit about that. How many people are affected? And what are some of the signs and symptoms that these women are experiencing?
Okay, so let's start with the definition so we can imagine where endometriosis comes from, and then from there we can imagine symptoms that women can experience. Endometriosis, it's a presence of endometrial tissue outside of the uterus lining. There are different theories why it happens. The most useful one is about retrograde menstruation, where when women have menstrual bleeding, they are bleeding outside, but also through the tubes, the blood can be carried into their belly. And there, the endometrium that mistakenly gets into the tube, gets into the ovary, gets to the belly, can grow. So you can imagine that if we have endometriosis of the tube, then the tube can develop adhesions, and this can be a cause of infertility. If the endometriosis develops in the ovary, then we can develop something called chocolate cysts, which means that endometrium grows in the ovary, takes the space of the ovaries, of the healthy tissue, takes away follicles, eggs, and can cause diminished ovarian reserve. Of course, when you have cyst, the cyst can be painful because it's a foreign body in your belly. So you can experience pain. The cyst can rupture. So you can experience acute peritonitis. You can have the symptoms like by appendicitis, that there is a blood in your belly that causes issues with your peritoneum, and this can cause signs of peritonitis. It's very painful. If endometriosis develops behind the uterus, it can cause adhesions with the loops, with our bowel loops, and then we can experience difficulty with our bowel movements. So the endometriosis can have many symptoms, but the most common one is pain and infertility.
And it can affect, I can imagine, with all of those possibilities of adhesions and cysts, I can imagine that there are different ways by which endometriosis affects fertility as well.
Of course. So endometriosis can cause a tubal factor when the tube is not open and inseminations do not work. As you can imagine, I'm still in a hospital, and I've seen today, patients with this kind of issues, that they have children when they were in their 20s, and now they are in their 40s, and the tubes are not patent anymore because somebody has endometriosis. So this is the moment where you have to do ICSI. People with ovarian endometriosis are patients where they have diminished ovarian reserve, where your AMH is low. And of course, when you have young patients, you have to see overall the ovarian reserve, your age, your AMH, and then plan treatment with your own eggs. But sometimes the ovaries are so destroyed that there is no ovarian tissues anymore, and the only thing you can do it's an egg donation. There are some patients that develop something called adenomyosis, means the presence of the endometrium in the uterus wall, and then uterus can be bulky, can be big uterus, and can cause implantation failure. So in this kind of cases, we down-regulate patients. We give them injection of hormones that stops production of FSH, LH, of hormones usually that are produced by the hypophysis. And this way, there is no hormonal growth of endometriosis anymore to keep a bulky uterus under control.
So it seems like these are very serious consequences of endometriosis, but for most women, it takes too long to be diagnosed, many, many years, until they might go to their GP, they might be told that the abdominal pain is normal. Why does it take so long, or why is it so difficult to realize that there is a problem of endometriosis?
Because when women say that they have pain, it's usually due to their menstruation or they are hypochondric. So nobody takes it seriously. And it takes quite often, a long time to diagnose, because the only way to diagnose endometriosis properly is to do laparoscopy, to enter with the camera through your belly button and see endometriosis fields in the belly. And we doctors, we do not recommend to do laparoscopy because somebody has pain. You have to see something in the ultrasound or in the CBC, in the circulating blood count, that makes you worry that you you can have appendicitis or a cyst or whatever. This is when you operate. But because of a pain only, with all the lab results and ultrasound, which is good, we do not, push patients to the operating theater. So patients with endometriosis, they go back to you, they suffer. And this is the moment where you say, oh my God, we excluded cyst, we excluded inflammation, we excluded different types of other conditions, irritable bowel syndrome. And this is the moment now that we do the laparoscopy to confirm endometriosis. So endometriosis, it's like the last thing that we usually think of. It's a diagnosis of exclusion. You have to exclude different conditions in order to confirm endometriosis through the laparoscopy.
And I imagine that it's a progressive problem that gets progressively worse with time, and treatment is also not easy, isn't it?
It's a very good question, how we treat endometriosis, Andrea. So when you go to the exam in the gynecology and obstetrics, is the most common question. And professors usually want to hear that we downregulate patients. It means that we put you an injection of GnRH analogs that stop producing of the hypophysis hormones. But this is the way that you treat endometriosis. You have it under full control, but patients have side effects of not having estrogens in their body. So you can imagine 20, 30 years old girl that has a diagnosis of endometriosis, and then I downregulate her, she doesn't have estrogens, and she experienced symptoms of the menopause. And she comes to you, and then she starts experiencing different kind of symptoms, hot flashes, irritability. She's dry, she doesn't have a sex life, which in this age is very important. So this is how we treat endometriosis. When you downregulate and patients start experiencing side effect of this, that there's no estrogens, we do something add back therapy. We add a little bit of estrogens to make them, survive this heavy moment. In this kind of treatment of endometriosis, it's something that you should say on your gynecology exam. But when a doctor with experience has seen these side effects in unhappy patients, then you say, maybe there is something lighter, maybe there is something milder that I can give to my patient so she doesn't experience these side effects. And the milder treatment which reproductive medicine develop are birth control pills, progesterone based only. I'm not allowed to say any brand names, but you can imagine what kind of pills it is. And then what you do is you operate a patient, you remove the cysts, you remove the adhesions, and you put them on progesterone-based birth control pills. And the second most important thing that you have to say on your exam in the gynecology is something called long cycle. Long cycle means that patients do not have any bleedings, they do not have any periods between one package of a pill and the second package of a pill. Because you can imagine, if you do not bleed outside, you do not have periods, you also do not bleed inside. So there is no endometriosis new growth in your belly. So there are two ways of helping you. Radical way with downregulation and a risk of side effects, or surgical removal of endometriosis, of all the problems that we discussed, and then having patients on long cycles with progesterone-based birth control pills. So sometimes people do not have, period for 3 years, and it's good.
But they also can't get pregnant when they are in those treatments, isn't
it? This is very, very true. Patients come back to you and they ask, oh my God, what do we do now? You let them try to get pregnant 3-6 months. And if they are not getting pregnant with endometriosis, then you usually recommend the assisted reproductive treatment. It's usually when they have good ovarian reserve, when they still have good AMH, it's ICSI, intracytoplasmatic sperm injection, or if they are in advanced maternal age, then you recommend them egg donation.
And is the chances of them being able to get pregnant naturally, does it depend on the extent of endometriosis?
It depends a lot. Because you can imagine if you catch endometriosis when somebody is very young and you put this patient on long cycle with birth control pills, this patient doesn't bleed inside, this patient doesn't bleed outside, endometriosis doesn't grow. So she has a very good chance to get pregnant naturally when she's ready. But if this girl does not get her endometriosis recognized quickly, then she experiences 10 years of regular bleedings, and then you see her with obstructed tubes or chocolate cysts, which you have to operate, and then her chances are a lot lower.
And when we're talking about IUI or IVF, is it even worth trying IUI, or would they just go straight from natural conception, trying naturally, to then going through the IVF cycle?
What can I say? I'm not a big fan of artificial insemination because the chances are low in this kind of treatments. So if I have a patient who cannot get pregnant, and on top she has endometriosis, I would like to have her pregnant as soon as possible, to have time to pregnancy as short as possible. I don't want her to experience too many cycles, too many bleedings inside or outside, because through this her endometriosis can grow. So my idea will be have her on birth control pills, get rid of big endometriosis areas like chocolate cyst, and then design an ICSI cycle where with good ovarian reserve we can generate 15, 20 eggs, 10 embryos on day 5 of development, and these embryos are frozen. They can be transferred now in 2-3 years for the second child. So especially in endometriosis, I would like to do a cycle with family planning, where at once we generate a lot of potential embryos for children that we can, and embryos which we can transfer now, and then have embryos frozen for the future.
And is it sometimes worth it to have the laparoscopy to remove some endometriosis before IVF? Would that improve their chances with IVF or not?
Yeah, the recommendation of American Society of Human Reproduction is when the endometriosis areas are small and are not visible in the ultrasound, we usually do not touch them.
Okay.
But if you have a cyst full with blood of 3-4 centimeters, the problem that we are facing is that during the pregnancy, uterus is going to grow, and there is not enough space for the uterus and for the cyst. And then the kid is going to grow anyway, because children are going to grow. And then when there is not enough space, the pregnancy can crush the cyst, and then the blood can get to your belly during the pregnancy. And this is the acute situation. You have to do the surgery. So gynecology, we prefer to get rid of this big cyst before pregnancy in order to avoid emergency during the pregnancy.
And if a woman with endometriosis is able to get pregnant, either naturally or through IVF, are there any concerns or any things they need to be aware of during the pregnancy, or can they just be followed up as a normal pregnancy?
They are usually followed up as a normal pregnancy, because in the pregnancy is more focused on the proper child development and conditions like thyroid issues, like sugar. If somebody who has endometriosis successfully gets pregnant, usually the pregnancy develops well, and then the endometriosis does not cause big problems, because, as I said, gynecology wants all the big endometriosis issues to be solved before the pregnancy.
And would you say that most people who get to you, do they have their endometriosis under control, or have they been misdiagnosed over the years and then get to you in a very bad state?
The awareness of women is a lot more advanced now than it used to be a couple of years ago. Women go to doctor, to gynecologist regularly. In UK, every 3 years for the smear test, and then majority of these women are offered the scan, the transvaginal scan, to see what's going on in their belly. So I have seen cases in my life, but I worked 20 years in gynecology, so I have seen very advanced cases. As a young, resident doctor in Berlin, we used to operate, chocolate cyst which ruptured. So for me, it's very easy to talk about it because I've seen it. In the last couple of years, I've been working in reproductive medicine, and I've seen cases of bad, big, bulky uterus that do not implant. I have seen cases of small endometriosis cyst which took away a space for the ovarian reserve and eggs. I would say that the number of cases, the advanced cases, is not that high as it used to be, because now girls, a majority of girls that study that, that are their career focused are on birth control pills. So this is how we do not see as many advanced cases as we used to see 20 years ago.
And so you are super experienced in treating these women, no matter how they are presenting with endometriosis. And I know you have a brand new clinic, Vida Fertility. Would you like to tell us a bit how people who are watching us, who think they might have endometriosis or they might need help, how can they get in touch and get help?
So I'm very open to see all the patients that need my opinion regarding their fertility or their endometriosis. The operating theater that we have has an amazing equipment where we can do in the clinic laparoscopy if you need this diagnosis. If you have an implantation issues, if you have IVF treatments that did not work, and endometriosis could be the reason, we will be more than happy to see you in our offices, and then give you a personalized first appointment, and then discuss in person what do you really need and what can we do for you.
And I also been told that you have an event coming up in a few days. Do you want to tell us about that?
We have few events coming up. So we are, you know, female dominated team. So in the moment where I'm talking now to you for English speaking patients, we have an amazing French manager, and she at the same moment she has a live event for French patients. We have amazing Dutch colleague. She had an event yesterday for Dutch patients. So this weekend, I'm seeing Dutch patients, and I'm seeing patients from England, from English-speaking world, from US. In 1 week, we will be flying to Berlin, which we are really looking forward into. We're going to be in Berlin first time after COVID. And in May, for sure, we are going to be back in London after 2 years. So I hope to see you, Andrea, in London for fertility show.
We'll be there. We also have a stand there at the fertility show. We'll definitely be there.
Sure. So these are the events that are coming up that I remember. Probably, you know, our marketing director, if I didn't say everything, she's gonna kill me. But for this weekend, the plan is clear: UK and the Netherlands. Next weekend, Germany. In April, there is a lot of events coming. I don't know them by heart, but I know that for sure in May we're gonna be in London. And all the patients that need us, I will not leave London without consulting you for endometriosis, for infertility, for egg donation, for whatever you wish.
Perfect. What I think I'll do is when I share the video, I'm going to add the link so that people can see all of those events, and they can go directly to your website as well.
Yes.
They can connect as well.
Sure.
But thank you so much for answering all our questions and sharing your wisdom about endometriosis.
Thank you so much, Andrea. You know that I love working with you. You are a sweetheart, sunshine, and you are a smart, you know, professional. So I really admire you for that. And I'm looking forward to having more live events with you. And definitely we have to catch up in London. I'm sending you the biggest hug from Alicante, and hope we stay in touch and see you soon.
Absolutely. Bye.
Take care. Bye, guys. You too. Bye, honey. Have a good one. Bye.